My name's Dick Bunt and I'm Chairman of the Dunedin Basic Medical Sciences Trust, and welcome. So good to see so many faces and so many interested faces here tonight. I want to tell you a little about the Trust. The Trust was started by a man called John Borry in 1957 as an aid for folk passing, at that stage, the Part 1 surgical exam. John also published a guidebook to London, which I'm gutted I haven't got a copy of, but will tell you what bus left what bus station at what time to go where. It really was the ultimate guide to London. John had a distinguished career. Apart from starting the Basic Medical Sciences Trust, he went to the UK. As you know, he was a prisoner of war, I think, for 4 years. He wrote a book about his experiences, and then came back and quickly got his English fellowship, one of the quickest people to get the fellowship in the English College, and he also became the Hunterian Professor at the College of Surgeons in London. He came back to New Zealand. He spent a year or two in Green Lane and then came down here and set up the Southern Thoracic Unit to treat mainly tuberculosis in those days, but other inflammatory diseases. Those of you who knew John was a wonderful human being. He was passionate about his surgery, but he was passionate about life. He had some fantastic sayings, but he always had as his main purpose in life to help, to aid people, to help students, to teach, and to help people get through their careers. I unashamedly admit he was the man who got me into cardiothoracic surgery, and I don't know whether I owe a lot to John, or people might owe a lot to John, but he was the person who pointed me in the right direction. John comes from past, present and future medical royalty. You'll look in the phone book and find many Borries were doctored before their name, and I think that's still continuing, just speaking to some of the current members whose next progeny are also going into the profession of medicine. So we wanted to set this visiting professorship up in honour of John. When John set the trust up, he then enlisted the help of the Heslops, John and Barbara, and as you know, John and Barbara passed on, but we made a significant contribution to the Heslop Trust too, in terms of what that's trying to do. We have 60 to 90 students that come to a 6-week course from Australia and New Zealand. It is the most successful course in Australasia. You want to pass your surgical exam, and that's all come from the embryonic seed that John Borry sowed in 1957. So this professorship is to honour John, and I'm pleased to see a significant number of members of the Borry family here tonight. When Jim Reed, who's also a driving force behind this, we nutted out who would be the ideal recipient of a John Borry travelling professor, then Murray Brennan's name was come right to the top. It is true that if you're down a particular profession and not widely known outside the profession, people don't quite understand the immense contribution that some people have made to their endeavours. It's fair to say, without embarrassing Murray, he's probably New Zealand's most famous medical expert in terms of what he's achieved overseas. He's a graduate of Otago, of course, comes back here relatively frequently. He played a few games for Otago with a large number on his back out in the 3/4, was a very successful rugby player. He then went to a very prestigious hospital called the Peter Ben Brigham Hospital in Boston and Harvard, became a fellow there, did research in association with Harvard and the Joslin Clinic, got interested in metabolic diseases, surgical metabolic diseases, moved south, and ended up being head of surgery at the Memorial Sloan Kettering Hospital, which is one of the most prestigious hospitals in America. His name appears on 1,000 publications. He's a man who can talk about 10,000 sarcomas and their treatment, and so in terms of experience and in terms of expertise, he was without peer in terms of what he can bring to any discussion. So, as I said, it was a no-brainer who the first professor would be, and it's my pleasure to welcome Murray here. We thank him very much for taking time. He's still very busy, and he's taken time out to come in and be part of this occasion. For those of you who drink a wee bit of wine, you might note there's a name Brennan Pinot Noir, who was just voted one of the top 10 Pinot Noirs in New Zealand. Slightly ahead of Rockburn, I have to say, but we're also in the top 10. But having said that, that's Murray's son who's growing grapes and making one up the Gippsland Valley. So thank you all for coming. It'll be a very interesting evening. And now I'd like to invite Michelle to come up.
Good evening, everybody. My name's Michelle Coleman. I'm from the Division of Health Sciences at the university. And can you hear me now? Sorry. My name's Michelle Coleman. I'm from the Division of Health Sciences at the university. Still can't hear? Okay, I'll try and speak very loudly. it's my job to introduce you to two wonderful people who are at the completely other end of the career cycle. Briefly speaking to you tonight are going to be two PhD students at the university, and they are the first recipients of the Macgibbon Travel Fellowship. This is a new fellowship which has been enabled by a donation from one of our alumni, Dr. John Macgibbon. John Macgibbon spent most of his life living and working in America at the Johns Hopkins University. And we're very grateful to Sir Murray for reminding John Macgibbon that this would be a very useful thing for him to do. So this funding has enabled and will continue to enable in perpetuity students from this university to go and work in America during their PhDs for between 2 and 6 months, or maybe even up to a year. And this is a fantastic opportunity for these students. And we have two people here tonight who are going to give you a little bit about their experience of working in America in research. So firstly, I would like to invite Deanna Barwick, who is currently doing a PhD in the Department of Anatomy with Dr. Andrew Clarkson, and she has spent some time at the University of California. So I'd like you to welcome Deanna.
Thank you, Michelle. I firstly just want to again introduce myself. So I am Deanna Barwick, and I'm doing my PhD here at Otago University. For my PhD topic, I am investigating ways to improve post-stroke recovery by targeting the molecular mechanisms. Sorry, is that the volume again? Or? Oh, okay. Okay. Like, is this all right? Okay, thank you. So firstly, I'll just start. Does that work? Ah, perfect. So I just want to start with what actually is stroke. So a stroke occurs when there is a disruption of blood flow to the brain. This disruption causes a lack of oxygen to reach the brain cells, which results in cell death, which can be the impairments we see in the patient. So there are two types of stroke. We have an ischemic stroke, which is from a blockage of the blood vessel, and there's also a hemorrhagic stroke, which is when the vessel bursts. So roughly 90% of strokes we see are ischemic strokes. So why is stroke important? It is a leading cause of death and disability worldwide, with millions of people suffering impairments each year. So in New Zealand, currently 60,000 people are living with a disability from stroke. So that accounts to roughly 2% of the population, so it's a very big statistic. So when investigating recovery, there are 3 important factors. First, there's rehabilitation, which could be things such as physiotherapy. This can be either physical or cognitive. There are therapies which we can apply, which could be drug or cell mediated to improve recovery. And thirdly, there's plasticity of the brain, which is the brain's ability to form new connections or remove ones which are already there. So it's been seen older people suffer larger impairments when the stroke size doesn't differ. This suggests that there may be an inability for the brain to form new connections or to remap old ones. It has been shown that if we can manipulate axonal sprouting when tracing, we can improve a patient's outcome. So while motor impairments have been the main focus with physiotherapy, cognitive impairments haven't really been looked at. And here in Otago at the Clarkson lab, we're trying to establish a model of cognitive stroke. Cool. So during my time abroad, I was based in Los Angeles at the David Geffen Medical School of UCLA. And I was working under the supervision of Professor Tom Carmichael in neurology. Tom is one of the leaders in the field of stroke recovery, and he is the expert in post-stroke repair. So in particular, the sprouting of new connections. So the fellowship allowed me to travel abroad and work closely with an incredible postdoc in Tom's lab, Dr. Tina Joy. And I worked on 2 in vivo experiments investigating axonal sprouting in stroke. So there were 2 aims. The first experiment we did to test a novel treatment on axonal sprouting following motor stroke. And the second experiment was to investigate changes in connectivity following prefrontal stroke. So the fellowship was an extremely useful opportunity in allowing me to learn new techniques from the most experienced in the field. I spent many hours in the lab perfecting these techniques and applying them to the experiments at hand. Preliminary findings show a loss of connectivity between regions involved in cognitive processing, and there's an early indication to show that we can rescue this impairment with a novel treatment. And since returning to New Zealand, I'm now in the process of establishing these methods here at Otago to do further studies and also to confirm our findings. So perfect. I would love to thank the alumni of University of Otago in America and also the Margaret Begg Charitable Trust for making this trip possible. Also an acknowledgement to Mbae for funding the project. And I'd like to acknowledge Dr. Andrew Clarkson at University of Otago, my supervisor, for your support. Ferry Institute, in particular Dr. Olga Zubkova. She's the one who's creating the compounds which I'm testing. And also special thanks to the University of California, Los Angeles, in particular Tom Carmichael for hosting me and Dr. Tina Joy for all their mentorship. Yeah, thank you so much.
Thank you, Deanna. This is the biggest group she's ever spoken to. Secondly, I'd like to introduce you to Amy Dowdle. Amy Dowdle is working in the Department of Pathology at the Dunedin School of Medicine and under the supervision of Associate Professor Julia Horsfield. And she has been working at the Stowers Institute in Kansas City. So without further ado, Amy.
I tend to be quite loud. Can you ever hear me if I just stand here like this? Can you hear me better now? Thought I'd give it a go. Can you hear me? Yeah, okay, great. Okay, so first of all, again, I just want to thank the alumni of the University of Otago in America for providing the fellowship to go to the United States for 6 months. It was a wonderful opportunity. I enjoyed it very much, and as you will see, it was a really excellent way to kick off my PhD. So I went to Kansas City, as Michelle mentioned, and when I told people that I was going to be spending 6 months in Kansas City, I invariably got two responses. The first being some kind of Wizard of Oz reference, and the second being, why? So, to the first, I usually responded with a polite laugh, despite having heard the same joke dozens of times already. And to the second, I answered, that was quite easy. Why Kansas City? Kansas City, because that's where the Stowers Institute is. So the Stowers Institute is this fantastic, amazing basic medical research institute. It's one of the leading basic medical research institutes in the United States, and if not the world. So it's a really, really great place to go and just do science. They have so many resources and wonderful, incredible, talented people that you are just able to go and knock on the door and pick their brains whenever you've got any type of problem, any type of issue, you want to troubleshoot an experiment. Everyone's door is always open. It was an incredible time for me and for my science. So the Stowers Institute, highly recommend, especially if you want to do any type of sequencing, which is what I did. I spent time in the lab of Jennifer Gerton, and she works on cohesin, which is a protein complex, so we are also interested in our lab. But if I talk a little bit about my research first, I'm in the lab of Julia Horsfield in the pathology department. Julia's here tonight. And we investigate zygotic genome activation in zebrafish. So we use zebrafish as our model organism. But zygotic genome activation is a process that actually happens in all animals, and it actually also happens in some plants. So what it is, it's a time in development, in early development, where the genes switch on in the embryo. So you might be interested to know, as I was when I began this project, that the embryo's genes are in fact off right at the beginning of development. So following fertilization of the egg and in early development's being driven by maternal factors, so proteins that were present in the egg at the time of fertilization. They're telling the embryo what to do, how to divide, how to develop. And the embryo's genes are off, and they're not doing anything. But at a certain point, and as you can see on this graph here, this figure along the bottom, this is showing zebrafish development across time. So the red is where the embryo's genes are off, but you can see that in a couple of small waves, the embryo's genes begin to switch on. And they take over from the maternal program. They shut down the maternal control of development, and they take over for themselves, which, if any of you in the audience are parents, you might like, that sounds a little familiar, right? So that's what happens. That's zygotic genome activation. But the mechanism for that is actually unclear. We've got some clues as to what might be happening, but we have no real picture of what the actual trigger for switching those genes on is. So that's what I was looking at during my time in Kansas City. So for the purposes of time, because of course I don't want to take away any longer from Murray's talk, I'm just going to talk a little bit about why the Macgibbon Fellowship was so great and what I gathered as a fellow during my time. So of course the biggest thing certainly that Julie is really excited about, my supervisor, and of course me for my PhD, is that I was able to produce just a stack of data. I was able to produce so much data because of the resources available there and the people I was able to enlist to help. And so I was able to produce data in 6 months. It would have taken at least 12, maybe 18 months in New Zealand to have done the same thing with the same level of quality. So that was, that's very exciting. Secondly, I was able to learn new skills and, again, go and pick people's brains, learn these new skills that I immediately brought back to New Zealand and started using straight away, particularly in the areas of bioinformatics, which is sort of notoriously a skill that's quite difficult to pick up, unless you've got people who are willing to be emailed at 2 a.m., which happens. So that was great. I was also able to establish collaborations. So with Jennifer Gerton, the PI whose lab I spent time in at Stowers, we've now formally got a collaboration between our two labs, and I also personally was able to establish my own network of connections, people who I can now call on to help if I'm encountering problems, or in future if I might like a job. And finally, it was really great to spend time in a different culture and in a different way of life. So Kansas City, of course, is very different to Dunedin in many ways, and America itself is vastly different to New Zealand, as I'm sure many of you can appreciate. So I just want to leave you... Oh. Okay, well, I'll leave you with a few photos that have been mysteriously rearranged. But there's a few photos of my time in Kansas City, or in Kansas, the wider Kansas area. Really, you're just missing some prairie grass, so it's okay. You can imagine what that looks like. And this is the Nelson-Atkins Museum, this is like a symbol. These shuttlecocks on the lawn are a symbol of Kansas City, and I would walk past them every night on my way home. And so for me, that's a real reminder of what my time was like at the Stowers Institute. So finally, again, I just want to thank the University of Otago alumni in America, Murray Brennan for the fellowship, and all of you here tonight for allowing me to spend some time talking to you. Thank you.
It's now my pleasure to introduce my friend Professor Sir Murray Brennan, who I think is probably the most illustrious living graduate of the Dunedin School of Medicine. He does come from, he is a graduate here just before my time, and he's the holder of the inaugural John Borry Professorial Fellowship. And we hope that this will be an annual event. We're going to have a John Borry a professorial fellow each year from now on. Murray spent most of all of his professional career in the United States, and he's held many prestigious posts. He is a Grand Companion of the New Zealand Order of Merit and one of only 8 in this country. I'm really going to introduce him with a story, which I promise you is a true story, and I'm sorry Murray has heard this before, and I hope I don't embarrass him. My wife and I were in London in the early 90s, and we went to, I think it was an Angus steakhouse, but it might have been a Tony Roma's or somewhere like that, and we were going out for a show. And we sat down in the restaurant, and there was a young man sitting just right in the next table to us, and my wife got up and went to the bathroom. And I got talking to him and it transpired that he was a young surgeon from New York. And he'd come to London to do a surgical course, and I said, "Oh, where are you working in New York?" And he said, "Oh, I'm very junior." He said, "But I've got myself a job at the Sloan Kettering." And as Dirk has told you, the Sloan Kettering is one of the foremost cancer hospitals or cancer institutes in the world. And I said, "Oh, you're working at the Sloan Kettering?" I said, "You might know of might have heard of a friend of mine." He said, "Oh." It's a very big place, and he said, I'm very junior. And I said, "Well, have you heard of Murray Brennan?" And he looked around like this. He said, "Murray Brennan?" He said, "You mean to say you know God?" I promise you it's true. Professor Murray Brennan.
Well, thank you. Does this work? I thought you gave me this thing to make it work. Then why do I carry this thing? Thank you very much. I hope those of you with any kind of faith look to a different God than me. John Macgibbon was an interesting man. He was a graduate. He spent 50 years at Hopkins, and I was... Excuse me, I'm your surgeon. Do you have any suggestions at the back? Okay. Does that work? Does it work if I speak loudly? Okay. So John Macgibbon was a graduate of the school. He spent 50 years at Hopkins. And when I was talking to him about giving some money to Otago, I didn't think that he would respond. And so I said something very foolish. I said, I know that you feel you should give Hopkins some money. And before I could finish the sentence, he said, hell no, they've got too much already. And so that was the reason that he gave this award. Now, we have to find it. So thank you very much for this very distinguished award. John Borry was a teacher of mine, and there's only one person to be more surprised than him that I'm standing here 50 years later talking to you, and that's me. But he did teach me a great deal, I must say. He had a lot more faith in me than I had at that time. You'll know he founded the training program that you heard. He was awarded several medals. He retired in 1980, and of course he died at 91. And you heard Dr. Bunton refer to the fact he wrote a book about his experiences as a prisoner of war, during which time he actually studied, I believe, for the exam he passed so quickly in London. So, Borry family, the Trust, the Foundation, thank you very much. How are we doing on the sound? All right. I've pleased someone in the room. If the talk's no good, it's your fault. What I'd like to tell you a little bit about is the role of the institution I've worked at for 30 plus years. And it's very interesting. Memorial Sloan Kettering was founded exactly the same year as the Dunedin Art Gallery. Art Gallery was first started, 1884. And it was founded by a man who was a gynecologist, and it was founded because in those days, women with gynecological malignancy were not admitted to public hospitals because it was assumed to be an infectious disease. So J. Marion Sims suggested we needed a cancer hospital predominantly for women with gynecological malignancy. He actually died before the hospital was opened, and it was predominantly supported, A, by the Rockefeller family, and B, by the Astor family, and they provide a lot of the resources. And we can talk about that over cocktails. I'm a surgeon. This is John Hunter. Surgery is like an armed savage who attempts to get that by force, which a civilized man would get by stratagem. 250 years ago, And I'm still a surgeon. I still believe that. 75% of all patients cured of cancer have a surgical operation of one sort or another. What Hunter was actually telling us, though, was not really how bad surgery was. It was the fact that biology almost invariably, if not always, will defeat technique. And I'll tell you about how that works. The evolution of surgery, particularly in the United States, and it really did develop for the world, was led by this gentleman, William Halsted. Now, Halsted, like Gibbon, of course, was at Hopkins. He was the foundation professor of surgery. And he wrote a memoir in 1907 about the results of radical operations for the cure of cancer of the breast, the Halsted radical mastectomy. And this was a radical operation. This was taking the female breast, the muscles beneath it, the lymph nodes in the axilla, the armpit, the lymph nodes in the supraclavicular fossa. Now, he was a professor, and he wrote and he documented his data. You don't need the details, but you can see he said what he did. He said how many people survived. And then, of course, he told what he did, either the lymph nodes in the neck and the lymph nodes in the armpit were negative, and those patients did a lot better than people who had what we call nodal metastasis. No surprise, knowing what we know now. But Halsted, like me, was a professor, so he then decided to interpret his own data completely unsubstantiated. For instance, interesting to note how late metastasis occurred in those cases without axillary involvement. Another reason for wide operating. Of course, the first statement's true, the second one is false, and neither of them are related. The other thing he said was that the liability, now there's no data to address this in the manuscript. It just says the liability of a bone to cancerous metastasis increases with its proximity to the site of the primary growth. Well, that would mean that every woman who had a breast cancer would get a bone metastasis in her clavicle or her humerus. He had to know that wasn't true, but it didn't matter. The other thing that was very surprising, he said the liver may be invaded by way of the deep fascia linea. So for those who are not anatomists, that means that you have a tumor in your breast, it grows down the abdominal wall, somehow gets through the wall, jumps across the peritoneum into the liver. Now, what was even worse, he had spent time in Europe, and more than 25 years early, Sappi had described the actual lymph node drainage to the axilla. So here's an example of what I'm going to do to myself a little bit later. It's a great temptation if you're a professor and you supposedly have some authority to provide the data and then interpret and decide something completely different. And every physician in the room has seen that happen. At the same time, of course, Virchow, who was a pathologist, had suggested that the reason you got spread of a tumor, the reason you got a metastasis, was the tumor went to small blood vessels, lodged there and grew. And that was sustained for a very long time. However, Paget had described the fact that the body was not, and we know this very clearly now, independent of the environment in which the cancer was going to grow. And remote organs cannot be passive. In other words, a tumor, whether it's from the breast or it, will actually select the environment they want and are favorable to growth. And we know that very clearly now. But as you'll see, Memorial Sloan Kettering did not accept that for a very long time. Plant goes to seed, its seeds are carried in all directions. They only live and grow if they fall on congenial soil. And we know that now, and we'll come back to it. But I'm getting sidetracked. At Memorial Sloan Kettering, they actually embraced the Halsted philosophy. It was a hospital of incredibly aggressive surgery. And these three people to the right, Urban, Brunswick, and Peck, were surgeons that saw bigger and better operations with a solution to cancer. Really aggressive operations. A pelvic exoneration is where you take out the bladder, the colon, the bowel. You end up with 2 stomas. It's a huge operation. And it was done predominantly at that time for carcinoma of the cervix because there was no other treatment. But they did have long survivors. Brunswick is interesting for me as a surgeon because we have an operation, it's called removing the pancreas and the duodenum, that's always attributed to Whipple. A Whipple operation. Brunswick, actually, a gynecologist, did that operation before Whipple, but he rarely has got it. Of course, the Americans are fantastically good. We are fantastically good, ignoring the fact that Krauss had done it about 40 years earlier. But no one talks about it as the Krauss operation. It's about the Whipple operation. Now, George Peck was a very interesting man, a similarly very aggressive surgeon. Now, he was an upper abdominal surgeon. He did operations on the stomach. He should have been the one that did the pancreas operation. Brunswick was a gynecologist. He should have been the person that did the gynecological procedures, but it was Peck who went to define aggressive operations, and he was the one that did the hysterectomy on Eva Peron. Now, that in itself is interesting because now we have an upper GI surgeon, because of his prominence, going to Buenos Aires to remove Eva Peron's uterus at a time when she already had metastatic disease, something that we know is completely absurd, to remove the primary in the presence of extensive metastasis. And of course, she died quite quickly thereafter. And there's a great story about the accusations that she brought it on herself because of her prior activities, when in fact it was probably Mr. Peron who was the villain, because we know it was HPV. The first alternative to these radical operations, of course, was as a consequence of the development of radiation therapy. And Marie Curie, first woman to win a Nobel Prize, first person to win 2 Nobel Prizes, and of course went on to die of leukemia, almost certainly radiation-induced. And that's James Ewing. Now, Ewing was the first clinical director after the turn of the century at Memorial. So he's a pathologist. He brings radiation to Memorial Sloan Kettering. He's got all these incredibly aggressive surgeons. He doesn't believe in aggressive surgery. He believes in radiation, but he has to deal with people like Peck and Brunswick. Ewing, in fact, challenged Paget. He wanted Virchow to be right. He wanted to say that these tumors went and they got into small vessels and then they just grew there. And as you appreciate, that's not true. Merely by the lodgment. He wrote a book on neoplastic diseases, probably one of the finest early treatises of the pathology, and he described a tumor that bears his name, the Ewing Sarcoma, something that I'd been interested in for a long time. He was one of the first people to recognize the potential for radiation therapy, suggesting in this incredibly aggressive surgical hospital that there was an alternative, a most unexpected source, experimental physics, a new and powerful weapon brought into play. Now, there was a gentleman, James Douglas, a mining engineer, a very powerful, wealthy philanthropist in New York, who was the first to bring radium to the United States, and it came to Memorial Sloan Kettering. The other person which is of great interest now, given what we know almost, 80 years later, William Coley was the pioneer of immunotherapy. He recognized, this is Coley in 1892, that patients who got their tumors infected, some of them went away. And so he developed a series of toxins, which were bacterial toxins, which were directly injected into the tumor, and described several of them. This is an example of his first case in 1899. After 63 injections, you can see this gentleman's tumor of the face has essentially disappeared. That was almost certainly a sarcoma. And initially it gained great prominence. But of course it fell into disrepute when other people couldn't reproduce it. That's his original paper. That's the description of what he did. And if you look carefully, it's probable in later life, for the physicians in the room, he almost certainly had a pituitary adenoma by the look of him. He's got a big mandible. This woman I met, she was his daughter. She was a woman who promoted the cause of, quote, Coley's toxins, was laughed at by many, but funded a lot of research at our place. And now, of course, immunotherapy is finally coming of age. And now we know, this is, Judd Walcock is a melanoma guy at our place, the evolving aspects of, doesn't matter, anti-CTLA, just looking at things that interrupt the body's response. You know, whenever we get an infection, we have an immune response, it goes away, the body has a way to turn that off. So this is the converse. The body responds to a tumor, and we stop the immune response from turning off. And it's truly immunotherapy because the patient gets treated, nothing happens. If anything, the tumor grows. You stop the treatment, and then 10 weeks later, it's gone. So that's a true immunological event. So Coley deserved considerable, and this is another example. Now, the other thing that happened, of course, at that time was the evolution of chemotherapy. And that, of course, came from another tragedy, because that came from World War I, where we noticed that nitrogen mustard knocked out the white cells of people. They died because they had no immune response. They had no white blood cells. So the thought was maybe that would work for white cell tumors, leukemias. The reason I put Cushing and Osler here is because, of course, Cushing, who was the professor of surgery at the Brigham, where I trained, was the person who was present at the time of Revere Osler's death from a brain injury in World War I. And he actually then went on to write the great definitive biography of Osler, although he was a surgeon, and won a Pulitzer Prize for that, for that biography. This is the first example of that. It's an example of the use of nitrogen mustard. It's hard for you to see, but this man has a big tumor here in his axilla. Almost certainly, in retrospect, it would be a lymphoma, as we now know, and that disappears with the use of nitrogen mustard. And that was done at Yale. And they described the use of that in 1946. Now, remember, we've got all these incredibly aggressive surgeons at Memorial doing bigger and greater operations. Ewing believes in radiation therapy, and along comes Goodman and Gilman to say there is another way. And they found that in these patients, and you can see they're all what we'd call lymphoid or blood-based tumors, that this agent could make a difference. And at nearly every age, some benefit was obtained. Now, at Memorial, they were the first to actually use a new antimetabolite. It was something called 6-MP, 6-mercaptopurine, and again, in the treatment of leukemia. Burchinal, Karnofsky, and Rhodes, and the physicians in the room know Karnofsky described a scale of how well a patient could tolerate it. Now, if you look carefully, this is in November 1953. So in the background, we've got Ewing has promoted radiation therapy, immunotherapy's been ignored, and the surgeons are still doing these bigger and greater operations. Now, this doesn't sound great, does it? Of the 55 children with acute leukemia, aged 2 to 12, hematological and clinical remissions after 2 to 9, these remissions lasted from 2 to 22 weeks. That doesn't sound very good, does it? But no one had ever seen a response to childhood leukemia. And this was the basis of the development and treatment of childhood leukemia. This is the James Ewing Hospital. This is where Ewing's there, and this is very typical of New York. After a little while, someone else comes along with a little more money, so he knocked the name off the building, and now it's called the Schwartz Building. And I expect by the time I get back, someone else will have given more money, and it'll have another name. But here we are, 1952. I've just told you about radiation therapy, chemotherapy, immunotherapy in the same hospital. Here's Urban saying, oh, the operation's not big enough. We need to take out more of the female breast, the female chest wall. We need to take out the lymph nodes behind the rib cage, behind the sternum. Something that Dr. Borry could do, but certainly I hope never did. Now, there's an interesting New Zealand sidelight to this. This here, you all know the story of the Chariots of Fire, and many of you will know the basis of that was, of course, the Olympic Games in Paris in 1924. Now, in 1924, Arthur Porritt from New Zealand ran third in the 100 meters. That was the basis of the Chariots of Fire story. The person, of course, who's supposed to have won the 100 was Eric Liddell, the Scotsman. But, of course, Liddell could not run in the 100 meters because the heats were on a Sunday, and his Presbyterian faith would not allow that. And Liddell, of course, went on to die as a medical missionary of a brain tumor in China. But that meant that Arthur Porritt, distinguished New Zealander, had Liddell won, would not have come third, he would have come fourth. But Porritt was one of the very first people to suggest that there was a lesser operation for breast cancer, female. He wasn't the only one, but he was at a time where he practiced the idea that a lesser operation had equivalent outcomes. And he wrote a very thoughtful, single-author paper in the British Surgery and in the Lancet summing up, one can fairly say, without decreasing survival, a simple method has been employed, eliminated deformity and reduced morbidity. Now, that wasn't a randomized trial, but he made that observation. Wasn't the only one, but he was one of the really pioneers. And so there's a contribution of another New Zealander. And this says, simple, down-to-earth, and therefore probably contentious contribution. How thoughtful that is. Increasing knowledge of the essential nature indicate each individual has a natural growth. You get that feeling of Paget. It's about the host-tumor interaction. And he articulated it very well. And, of course, he came ultimately to be the Governor General. I met Porritt. Porritt was a visiting professor at the Brigham when I was a resident. He's one of only 2 people who was ever to be a pro tempore visitor at the Brigham twice. And this was before any randomized trial. This was 25 years before we began randomized trials in the United States. So that piece, it says that you should recognize people who went before you. I'm just checking the time. And a number of examples of that. These 2 gentlemen, Stewart was a pathologist, Treves was a breast surgeon, and in the first edition of Cancer in 1948 described an entity that occurred after these aggressive operations. And I'm not quite sure you'll be able to handle all these pictures, but nothing I can do about it. So they described an entity called Lymph Angiosarcoma that developed in the presence of these complications of these big operations, these big radiation fields. This is a patient of mine. This is not radiation-induced sarcoma, because you can see this woman has a lesion there, she has one there, the radiation field is up here, has it there, and this is essentially a death sentence. It's important because we now know that there are both lymphedema, swelling of the arm, and radiation-induced sarcomas. If you just look at these patients followed at the Institut Curie, where when you'd expect 1, but there's multiply it by 4, there's only 3,000. 4 sarcomas, 35 were seen. So we know very clearly that radiation is associated with the development of cancer. It's uncommon, but it's very important because, in fact, in the United States and perhaps in New Zealand, the majority of women with this disease, ductal carcinoma in situ, which is called carcinoma but really isn't, receive radiation. And they receive it based on very good information. Randomized controlled trial of the use of radiation or not following an operation for this disease. And there's no question the incidence or prevalence of local recurrence is halved, a good event. But if you look carefully, there is no difference in ultimate metastasis, which of course is the cause of death. But what's even more important is that of those that received the radiation and recurred, 90% could be rescued by a single operation. Now, this is standard of care in the United States. But for those of you with high school math, just think about it. If everybody received radiation, 12% recur, 8% cannot be resected. Less than 1% actually can be salvaged. And the converse, if everyone gets radiation, 27, if nobody gets radiation, basically the numbers say that the overall benefit actually is less than 1%. Why is that important? Well, it's important because there are lots of side effects of radiation, and here's a typical example. Apologies for those of you not comfortable. This is a patient of mine, a young woman, has DCIS, comes in, and she's got a large sarcoma involving the breast and chest wall. No problem. I can remove that. I can resect the chest wall, replace it, put it back together. But 6 months later, her chest is full of tumor. And we've replaced a non-lethal disease with a lethal disease. Now, I'm not saying that people should not get radiation. I'm saying, and we'll come to a solution to this problem, it has to be done much more objectively than we've done in the past. Because we're actually making this diagnosis 16 times more than we did just 25 years ago. The disease was always there. And if we know that we're going to make this complication, then it's exaggerated. Fortunately, people are beginning to realize that, and it's going to change. One of the things that's allowed me perhaps to have some success was that I was fortunate enough during medical school to do a degree in mathematics. And that helped me enormously. I didn't know what I was doing. I did a certificate of statistics. I was not the #1 student in the class by any means. If I was in the first upper 50%, I'll take it. But I did have this background to begin looking at things, and subsequently began to examine sarcoma. And we recently described our first 10,000 cases of a tumor. Why is that impossible? Because it illustrates the value of prospective databases. And you're just in the process nationwide, as I understand it, beginning to invest in big data management in the medical profession. We began that in the early 1980s. The other great attraction, we didn't even know when we began to bank tissue, putting it in a freezer, that subsequently we would have all these genetic analyses, which would be correlated to databases that are now 30 years out and mature. I don't need to tell you how we did this, but basically what I want to demonstrate is that the databases actually provide knowledge-based care. And the future of cancer care is not about whether I'm a surgeon or a radiation therapist. It's about the knowledge of the disease. And that's sometimes hard to get across to surgeons, hopefully not to you. But if you look at these databases, we can show things. It's men and women get the same. We can show where the tumor goes. We can show what kind of... But if you examine outcome just of a database without any interference, it actually can tell you about how the treatment might be designed. Let me slowly illustrate this. So here, So here are patients. I've just taken local disease, the person who gets a local recurrence. The tumor comes back at the local site. And if you look at the purple line, that happens to be what we call visceral tumors, 2,000 cases. And here is another different entity, what we call retroperitoneal. And they're clearly, the likelihood of local recurrence is very different. Now, when I was a medical student, I was told that if you got out to 5 years, you're cured. But look at this disease, it never quite goes away. So we immediately recognize that 5-year survival is a relative event. But more importantly, this tells us, if we now look not at local recurrence, but who dies, disease-specific survival, who dies of this disease? Well, suddenly, the purple tumor is down here. Remember, the local recurrence of the purple was up here. And the red line is pretty much the same. So what that tells us immediately, these people must die of metastatic disease spread elsewhere, and these people must die of their local tumor. It's no point in giving intravenous chemotherapy for the local recurrence, and there's every reason to give systemic overall treatment for those who die, and all we've done is record the data. So I'm very much encouraged by this governmental design. You have to invest in big data. Now, we began this 30 years ago, but the opportunity to learn things, whether it's by any form of analysis, but big data mining is coming. That just says the histology. But what it also tells us is I can just look at the site and tell you what's the likelihood of a particular histology. And that will change how I treat people. That if I look at that, I can look without anything else, just looking at the grade, which is the degree of aggressiveness of the tumor, and the size of the tumor, something that's available before an operation, and say, well, if you have a high-grade tumor, your chance of dying of the disease is 40%. You have a low-grade tumor, not a very sophisticated observation. Look down the microscope, say, looks bad. Look down the microscope, doesn't look bad. But the fact of the matter, it translates into an extraordinary difference. You don't want this patient to receive essentially any treatment, but you want this patient, particularly if they're sitting down here, to receive some form of treatment. And all we've done is write down the records. We haven't done anything different. We haven't intervened. Just make sure I got the right time here. Well, it doesn't matter. The other thing that says is that a local recurrence, something that comes back at the site where the tumor is moved, is not necessarily the cause of the metastasis. Because think about this disease. If a local recurrence of a tumor that occurs in your leg or your arm is the cause of your death, then I take off your arm, you can't recur, you can't die. And we know that's not true. And so that changed how we began. In the 1975, every patient I saw who had a sarcoma of the limb lost their limb. They had an amputation, a morbid amputation, often losing the hip bone, everything. But the fact of the matter is the local recurrence was not the cause of the recurrence. We have to get over that concept. Oh, that just says the same thing. These variables that we can see are not independent. They come together. So we have to think again in a data mining sense. How do we put these conflicting events together? And that says the same thing. I realized the time. The other thing we've learned is that these are recurrences. How does a tumor get a metastasis? Well, if it's an aggressive lesion, a high-grade lesion, then the majority occur, 50% recurrence, within the first 5 years. So the way in which we look at these tumors is very aggressive follow-up here. But these who go on and at 20 years are still having some recurrence, we don't look at them so aggressively, but we never stop looking at them. And all I've done is written down the data. I haven't interfered or done anything as yet. That just says the same thing. Molecular diagnosis is when we look at the tumor and we find a gene that describes that tumor. This tumor, it's called Synovial Sarcoma. It was given that name because when I was growing up, it was a tumor that occurred in young people, it occurred around the joints, and it was said to come from the lining of the joint. We know for sure it has nothing to do with the lining of the joint. But until we had a genetic signature, which it happens to be, it doesn't really matter, it's a fusion gene, it's two genes coming together, we wouldn't have made the diagnosis. But because in 99% of these, they express one of these fusion genes, we now make the diagnosis completely differently. And what that means is, I was taught it was always a disease of young people. But now we know, because of that genetic signature, it can occur throughout lifetime, something we never would have done without that signature. And the same thing, well, I was told, it only occurs in the extremities, but you can see it occurs everywhere. And in fact, we've seen it in places like the nasal cavity or the parotid or the brain. So a genetic signature allows you to make the distinction, and that's the future, genetic signatures for most tumors. Oh, that just says the same thing. The pattern of metastasis, where the tumor goes, will actually tell you how to treat them. Haven't done anything. If the tumor has a propensity to go to a lymph nodes, then removal of the lymph nodes may be valuable. But if, in fact, as in sarcoma, it rarely goes to lymph nodes, then what I was taught, take out the lymph nodes, makes no sense. And we now know that. And that just says the same thing. The other thing that we know, of course, is that the site of metastasis, where the tumor goes, if you know that, then that guides your investigation. If the tumor, as in the extremity, almost invariably goes to the lung, then it's a chest x-ray or a CT scan. If the tumor is a visceral sarcoma, which almost always goes initially anyway to the liver, then it's an examination of the liver. So these ideas of blanket, oh, doctor, don't I need a PET scan? Don't I need a whole body scan? Don't make sense. And we can guide that much more carefully. I think tomorrow I'm going to talk about what's wrong with the US medical system. And one of the things that's wrong, just one, there are many, is that we over-investigate. And that's expensive and doesn't help the patient. The other thing we can do if we've got big data sets, which you will begin, is we can begin to decide about how people, what defines response and how well they will respond. We can do lots of different ways. The key thing is, the first thing is easy. How do I look at your tumor and tell you what's going to happen to you? And the first thing we did, this is just one of our fellows years ago, it depends on what you want to know. Everyone says, well, I want to know how well I'm going to do or how badly I want to go. Well, what do you want to know? Do you want to know whether you're going to recur with a local recurrence, or do you want to know if you're going to die of the disease? Very different observations. And they're intriguing. It's no surprise you're going to get the tumor come back in the same place if you leave some behind or you already had one previously. That's easy. But if I'm going to die of the disease, well, I told you aggressive tumors causes your death, but how is it that the original tumor with a positive margin, let microscopic disease behind, is a causative event, or certainly associated event, with a disease-specific survival, death or disease? That has to be biology. It can't be any other answer. It's not a failure of the surgeon, because I can get rid of this if it's in your leg. I take off your leg. But if you're still going to recur, then that's of no value. The other thing we can do is, and you'll see more and more of it, is to actually take these mathematical models, and this has helped me a great deal, and actually take factors that we wouldn't have thought made a difference, put them into a model, and actually predict not just how you will do as a group, but how will I do as an individual patient. This describes what we do, but basically it's a tool that says, I want to be able to say that the predicted outcome here is the same as the observed outcome. And if this is a straight line, that's a good nomogram. That's a good model. Then all we have to worry about, let's make this tighter and tighter so it's an extra model. And we've done that in multiple diseases in our own institution. And what it does say, it says for a patient, for 100 patients exactly like you, we would expect X plus Y to recur. That's not like saying you're in a bad stage of tumor. That's about saying what's going to happen to you. And as long as this plus Y, the variance is small, that's a powerful predictor for the individual patient who's sitting in your office. And we've spent a lot of time doing that. That says the same thing. We've validated. The other thing you can do, you can take these nomograms, these predictive models, and make them, where is my tumor? It's a lung cancer. Is it a specific histology? How will I do? Is it time altered? Doctor, you took out my stomach a year ago for a cancer of the stomach. How am I doing? How am I going to do? Cynical answer is you're here today, so you're going to do a lot better than if you weren't here today, but you're not allowed to say that. But you can then say, has my survival been altered? And the answer is, of course. But more importantly, you can say, how much has it been altered? If my risk of dying was 90% 2 years ago, and I'm here today, what is it now? Well, it might in fact be 30%. A very powerful tool. Again, emphasizing this data management. Now, we have a big problem in the United States because we can't possibly afford the healthcare that we're providing. So how are we going to fix that? These are some of the things. The one I want to talk about briefly, is self-critique. Because I've been critical of others. I've said others have made. Let's criticize some of the things I've done. Now, I did what's called a randomized trial. I took a group of people that had this sarcoma, and I randomized them in the operating room. Flip of a coin. You get radiation or you don't. And I was delighted to know that I made a difference in terms of local recurrence, about a 20% difference. And I've followed these patients out 10 and 15 years. It's sustained. So I congratulated myself. I've made a difference. But then I looked at what happened to survival, and there's no benefit to survival. So that says the same thing as I said before. If local recurrence was going to kill you, then take off your leg, take off your arm, and you won't recur. But it doesn't. So that made me think about something that I should do. That I really began my career only interested in the benefit. And most doctors do that. We want to make a difference. We want to help people. But the fact of the matter is, none of these treatments, and the details don't matter for the non-physicians, are without some risk. There's no intervention that is without risk. Even doing nothing is not without risk. And people get complications from these diseases. And what it says is that when you read trials, the number one grade 1 evidence is a randomized trial, but they only apply to the people in the trial. And we don't seem to be able to get over the fact that we do a trial and we tell you this works. Does it work for me? Would I have been in the trial? And I'll illustrate that very simply. We looked at this trial and I told you that we halved the local recurrence rate. But I looked at all the people that could have got into my trial but didn't. And in fact, their local recurrence was exactly if we'd treated. So these people must have had a much greater risk that entered the trial. And we never talk about that. So I began to think about, how do I change that? How do I think differently? And I thought about this idea, doesn't matter what the trial is, but we've got a trial, and this is one of you are sitting on here, and you were never going to recur or die or anything. And so you could not benefit from anything. You weren't going to recur anyway. These people up here got a benefit from it, but the people above the line, they died or they recurred, doesn't matter. So they didn't benefit. These people couldn't benefit because nothing was going to happen. So it all came down to, how big is this difference? How significant is that? What does it mean to have deathly majority? It's not the benefit, but the consequences, because everybody gets side effects. So let's just walk through. Again, a little mathematics. Doesn't matter what the trial is. It's my trial, so I'm able to criticize it. So 70% didn't recur. They only got the side effects. 10% got the side effects and they recurred. So it's this 20% in the middle is the only thing that matters. And we've got a trial, it works, and we say standard of care. So that means 100% of people are going to get it, knowing that 80% cannot benefit, either because they don't respond or they get only the side effects. The whole idea of informed consent, do we talk to patients like this? We say we are sure that we have an intervention that will improve your survival by 20%. That's what we say. We don't say we have an intervention in which there is an 80% chance it will make no difference because 70% of you don't need it and 10% won't benefit. That's not what doctors do. And if you think about it, it's not what I did. I do now, but I didn't then. If you make those numbers very small, 90% of women with early stage breast cancer will never occur. But we know with an intervention we can get that to 92 or 93. We say unequivocally we can improve your survival. It's true. What we don't say is for any one of you to benefit, 49 have to be treated. We don't talk like that. And that's what we need to begin to do. That's one of the things that's wrong with our system. 20% benefit may not be so great. It sounds great. It's what I want. But if you take people who have already got metastatic disease to a particular organ, that 20% of benefit, not my data, may in fact be a survival benefit that's measured in a month. Is that valuable? Well, it might be. But we don't talk about it in that sense. This is one of my favorite slides. This is a very good journal, peer-reviewed journal, very respected author. And he, remember in the US, you have to do a randomized trial to get the drug approved so that the FDA will pay for it. And then if you're Medicare's not now allowed to negotiate, they must give it to you. So all that the drug company wants is that this p-value is real, that it's significant. But walk through it a little carefully. It's measured in months. Now this is advanced pancreatic cancer, bad disease. I've spent a lot of time looking. 6.24 months. Now, why would you describe survival as 2 decimal places of a month? 1 decimal place of a month is 3 days, as I understand it. 2 decimal places is 7 hours. I know I can have a positive trial. I will just delay the CT scan by a week, and my trial will be positive, and Dr. McKnight's will be negative. And yet, this is what we do. It's not that we're telling lies, it's just that we're not being honest. We're not interpreting the data. And this is the same thing. Now we've got a problem. We're measuring survival in weeks. Sorry. And we measured it in decimal places. Randomized trial, 7.3 versus 8. Incredible significance. But it's all due to the high numbers. That wouldn't have happened if there was 20 in either group, would it? And we don't. That's not how we describe it. So, having been incredibly critical, let me describe the good news. The solution is we've been focusing on the wrong end of the curve. Now, we didn't know that. We set out to make a difference. I wanted to make a difference. But now we have the tools to focus not on this end of the curve, but to focus on this end of the curve. We now have tools to predict who isn't going to recur or who is going to recur, so we can make better judgments. And I could spend a long time talking about that, but there's lots of ways. We can talk about predictive variables based on risk. We can talk about nomograms. We can talk about genetic signatures. This is an example. This is a randomized trial of a particular drug that works for a particular tumor who has a particular mutation. But then we look at the mutation, and within that mutation, there's only one variation of that mutation that responds. And yet in our community, if you had this gastrointestinal stromal tumor, it's called, if you went to the doctor in the US, you would get this drug. If you came to our place, you'd have mutational analysis, and you'd only get it if you had the mutation we know is going to respond. And that's the future. We just published, the institution, not me, the analysis of 10,000 cancer patients in the last 8 months with a gene signature of 480 genes, identifying targets that we never knew existed before. That's the future. That's beginning to be starting back here. And there's lots of other ways we can do that. We can use a PET scan that says, at the start here, you've got a very active tumor. It takes up glucose. We treat you, and if 1 month that take-up of glucose hasn't halved, you will not respond to that regimen. Stop, change, different direction. So we have lots of ways to approach it. And it looks like I'm in time. So what's happened? Well, I started out, I'm a surgeon, discipline specific. You have a tumor, I'm a surgeon, I can take it out. Then we began to say, well, wait a minute, maybe it's organ specific. Maybe we should only focus that on the colon cancer. Then it became disease specific. I want to understand your disease. And then it is, and you've got a molecular signature. But even beyond that, now you've got a pathway that drives your tumor. Not just the signature, not just the accelerator, but the combination of the accelerator and the brake. And that's really where modern cancer care is. It's between the accelerator and the brake. We're not in the main where you can turn the switch off. The engine's still running, but you're not going anywhere. And so instead of dying of cancer, you're living with cancer. And that, in the short term, will be the future. This just says the same thing in genetic signature, because what it says is that now we may treat a person who has a lung cancer and a person who has a head and neck cancer or an ovarian cancer. And because their signature is the same, they're treated the same way, as opposed to what we did historically. And so I think that's probably all we need to say, I think. Thank you.
Just to complete the evening, first of all, I'd like you just to show your appreciation to Sir Murray once again. And I would like to introduce Dr. Philip Borrie, who is the son of John Borrie.
Sir Murray, I'd like to thank you for a fascinating and enlightening address on the evolution of cancer care. It's a tremendous honour for the Otago Medical School and for the Basic Medical Sciences Trust to have such an illustrious person to be the inaugural John Borrie Professorial Fellow. Our family are honoured to have you here, and we are very moved by what those behind the trust have done for our father. In particular, I'd like to thank Dr. Jim Reed, who's done a tremendous amount of work to set this up, Mr. Richard Bunton, and also to Sophia Mackay, who's organised this function tonight. A huge amount of work. Thank you. Dad was passionate about his clinical practice, research, and teaching. From the mid-50s through to the early 70s, he carried out significant surgical research using sheep to do heart valve allografts, tracheal resections with celastic implants, along with early work around lung transplantation. I can remember on occasions when we went to our family retreat at Waitati, there would be one such surgical sheep that had survived, and it would be in the back of our station wagon to be taken out to the Beach Society field. And then sometime later, maybe 6 months or a year later, Michael, Louise and I were sent out to count the number of sheep that were there and report back to Dad. Dad always believed that you should look to the future and embrace change. Murray, your eloquent address tonight demonstrates the extensive change in cancer care, and it's just shown us something of the tip of the iceberg as to where we're heading, and I think it's just amazing. I'd like to take you back briefly to 1899 and give you a brief insight into the change in general practice over the past century. My grandfather, William Henry Borry, entered the Otago Medical School in 1889. 3 years later, he sailed to Edinburgh to complete his training in 1894. He returned to New Zealand in 1899 with the intention of setting up general practice in Dunedin. The general practitioner in Port Chalmers at the time, Dr. Cunningham, died unexpectedly, and William Henry agreed to do a 6-month locum. 26 years later, in 1925, he moved to Dunedin to set up general practice at age 54. I would like to read just a brief 2-minute extract from Growl You May, Go You Must, which includes 40 brief histories of early New Zealand doctors, nurses and patients. Port Chalmers at the time was a very busy port, but the medical practice extended far beyond the limits of the town. To the northwest, to the Kilmog, to the northeast, Aramoana, and then on the peninsula from Larnitz Castle down to the Otago Heads. In his house, there was no radio. It was not even thought of then, nor any walkie-talkie. To conserve effort, just 3 telephones downstairs in the hall. The first was the general telephone, complete with handles and batteries, number 10, Port Chalmers. The second was a party line for night calls, and the third was a direct line to the Port Chalmers stables. When the phone went at night, my grandfather instantly awoke. His call was 2 long rings. If it rang 3, he would sigh with relief and be asleep before the 7 long rings if the harbour board had finished sounding. But if he went downstairs to answer the telephone, my grandmother, listening in bed, would know by the prepositions he used just where he was summoned. If he said, "I'll come down," she knew it was to Zebrafish or beyond. If it was, "I'll come out," she knew it was to Sawyer's Bay or up to St. Leonard's or Burke's. If he said, "I'll come round," that meant a near trip to Port Chalmers Peninsula or Carey's Bay. If he said, "I'll come over," she knew that meant an all-night ride over the hills to Waitati. Or "I'll come across," he had to make the crossing to Portobello in an open boat, with the prospect of a grim ride to Broad Bay, Sandymount, or even Cape Saunders. He'd then ring Portobello on the night phone, and she would hear, "Is that you, Bloy? Can you come over by launch for me?" But if the weather was rough, he would have to bring the SS Tarawai, and most likely arouse the engineer as well to share the trip. For calls on the Port Chalmers side of his practice, he then rang a 3rd telephone direct to the stables. "Is that you, Mrs. Stevenson? Tell Asher to saddle the horse. I'll be down in a few minutes." Having read that, I can now understand why my father was so keen to embrace change. The name Murray Brennan was mentioned in our house from time to time, more recently in recent years when Dad reminisced about people he had met and taught at the Otago Medical School. Murray, he was so proud of you and delighted to see that a keen young Kiwi had scaled the heights of the American medical system. He knew the determination, the dedication, the commitment, and the sacrifice that you gave to achieve what you have done. I'd like everyone to join with me in thanking Sir Murray.